Okay. Welcome to our group presentation. We are the bipolar disorder group. We are group number 6. Our group is composed of Lauren Schur, Rabiatu Abdullahi, Deja Hamilton, Madison Hankins, and myself, Leslie Sandoval. Next slide.
Assessing and addressing stigma and bipolar disorder, the impact of treatment information on stigma. The article talks about how people view bipolar disorder, a mental health condition, and how we can change those views to be more positive. Researchers did a study with 2 parts to show how explaining the cause and the treatment of bipolar disorder affects what people think about it. They found that when people hear that bipolar disorder might be caused by genetics or biology, they feel less like it's the person's fault, but they also feel more scared of them. When people hear about treatment for bipolar disorder, they are less scared and feel less like it's the person's fault. The study suggests that giving people the right information about bipolar disorder can help reduce stigma and make things better for people with the condition.
I worked on this study. I found it interesting to add, so I decided to add it. It's about emotion in bipolar 1 disorder and the implications for functional and symptom outcomes. The study is about people with bipolar, and they used 4 analyses to measure. Those analyses are negative emotion, positive emotion, repressal, and suppression. And they found out the bivariate analysis showed that those with bipolar disorder were tied to a host of emotion disturbances. But the multivariate analysis showed that bipolar disorder was particularly tied to elevations of negative emotions. So at the end of the day, it was determined that mostly what really causes bipolar disorder and what really enhances it or makes it severe in most cases is the negative emotions that are enhanced compared to the positive emotions. Next slide, please. This is about medication adherence among female inmates. The study was conducted to compare those differences in adherence. So they used TIMA, which is Texas implementation of medication algorithm, TIMA, or treatment as usual. And they found that at the end of the day, there was no much difference between the two. It doesn't matter if they were using any of those measures. Bipolar disorder essentially does not really depend on what the adherence is all about, because some can, because of those factors I showed in the slide, the one that says that bipolar, the high baseline adherence exhibited greater decreases in daily adherence over time. But then that the TIMA participants missed, they had missed lower doses, but at the end of the day, it doesn't matter because they still show that medication adherence doesn't depend on the medications. Next slide, please.
And this was my part of the project, the case background on the case study that we were looking at. So the gentleman in question was a man by the name of George Lawler. He was a 25-year-old married male, father of 2 children. And for his career, he worked as a track coach at a small junior college. But he recently had a drastic life change. He suffered from a mental breakdown after pressure from his college for his undefeated track teams to succeed in their final meet of the spring. And George did have a past history of mental illness. His depressive episode during his junior year of college while playing football, so he suffered from that, and he really didn't attribute it to anything at the time. But if you were to look at his case study, it's pretty obvious that whenever the pressure is kind of hot under his feet, he seems to suffer from these mental breakdowns more. And then he would have periods of unusual ambition and energy, staying awake for long periods of time. The case study specifically mentioned some of his classmates had to take stimulants in order to stay awake, coffee, 5 hour energy, Red Bull, you name it. But he was able to just kind of power through for days on end and stay awake in order to study for finals. And then he had 2 other depressive episodes before his most recent hospitalization, which were brought on by worrying over his track team's performances. And his psychiatrist, which his wife Cheryl had set up for him, his psychiatrist prescribed lithium carbonate, which is both a mood stabilizer and an antidepressant. A little bit more on this background from George. George's mental breakdown, that is kind of where the case was leading up to. His first full manic episode developed near the end of the following track spring season. And there was some strange behavior being observed by George's wife prior to the track meet. I think he was kind of really, really worrying excessively over his team's performances. And then on the day of the meet, while the men's team was changing in their locker room before the meet, George was pacing quickly through the aisles and gesturing emphatically and talking in a incredibly manic fashion. He gathered the men's team in their locker room, and he brought a ceremonial sword from home, and he gathered them around his locker. And then he started swinging the sword over his head and singing the school's fight song. And I guess because this was a sports event, this was well received by his team, and they did win the game. And everyone was kind of like, "Oh my goodness, yeah!" Like they were getting all hyped up about it. But after the event, he did not go home that night. He stayed at his work in his office, and he was interviewed the following day. But during the interview, which lasted for over 3 hours, he only ended up rambling in a grandiose fashion about himself, his achievements, and he made a startling and inappropriate announcement during this interview, which was that he was going to send his star female jumper from his women's track team to the NCAA national meet with proceeds from the most recent community fundraiser. The sports department after this interview was understandably concerned. This is a married male. He has no business taking a female alone to meet, kind of singling her out, super inappropriate. And then another thing was that these proceeds were meant to be for the entire team, not just for one student. And so the sports team understandably was, or the department was understandably concerned with the content from this interview, as well as his most recent manic behavior. His wife was also concerned and realized that he might be a danger to himself or others. And he was then at this point admitted into a psychiatric hospital.
And this was my slide for this project. So I did case question 1, and the question says, patients with bipolar disorder are often reluctant to take their medication because they don't want to give up periods of hypomania when they feel exceptionally upbeat and productive. What would you say to a close friend with bipolar disorder who did not want to take medication? So one of the excerpts from the book said, in a hypomanic episode, the mood change must be noticeable to others, but it must not lead to marked impairment in social or occupational functioning or require hospitalization. And then periods of hypomania are periods of overactive and high energy behavior that can have a significant impact on an individual's day-to-day life. They will usually be able to continue with their daily activities without being severely affected or impacted. After knowing all of this information, many of the topics that I came up with, or I guess comments that I came up with. So the first one, I would validate my friends' feelings. I will make them feel seen and heard. The second one is I would ask if there is a particular aspect of the medication that they do not like. Do they fear being addicted to this medication? What side effects does the medication make you experience? After giving my friend that space to open up about their feelings, I would remind them that they are not alone. My goal would be to to make my friend feel like they are seen and heard. I want them to know that I am not judging them for not wanting to take their medication. I genuinely care about them. If there is an alternative medication or method that works for them, I would like to know about it. The medication might make them feel hopeless. It can be damaging to their personality and sense of self. No one should feel like they are a problem. They should not blame themselves for bipolar disorder because they did not cause it. Thank you. Next slide.
And I worked on case question 2. It states bipolar disorder can have a devastating impact on family relations. Is there anything about the behavior of bipolar patients, especially in a manic episode, that might make it particularly difficult for a spouse to understand and accept the person's behavior as being part of a physiological disorder rather than bad judgment? I started with looking at what the DSM-5 states about the manic episode. It lasts at least 1 week. It presents every day with at least 3 of the 7 symptoms. Some of the symptoms can include low self-esteem, a less need for sleep, and involvement in activity in like high consequence activity that can be painful to the patient. The lasting effects of this can be devastating to all parties involved. So that includes spouse, kids, and family members. I said the spouse could see this as a way of being rebellion against everyone and can cause problems within the relationship. Once we understand that manic episode only lasts a short period of time, by the behavior being unusual, we can see how the spouse can find it difficult to understand the behavior. By lasting a short period in time, the spouse can feel confused within the manic episode and overwhelmed or also afraid. Next slide.
Okay, so I did case question 3. The first question there is, what evidence supports the decision to separate bipolar disorders and depressive disorders in the official classification system? I got a lot of materials. I wanted to do a lot on that, but the limitation for the slides and the fact that the time for presentation will be very, very small. So I decided to just go straight to the point. So it says, a conglomerate of genetic and neurobiological findings supports the intermediate position of bipolar disorder between schizophrenia and unipolar depression. That's by Tanden, 2017. The next question is, what ways are they similar? Bipolar depression shares clinical features with unipolar depression, that is, depressive symptoms, tendency towards an episodic course, family history, comorbidities. Bipolar disorder also shares significant features with schizophrenia in terms of symptomatology, genetic markers, family history, response of mania to antipsychotic agents. That's by Tandon, 2015. And the next slide, please.
It's there.
Okay. The next slide, please. Oh yeah, I see it now. Thank you. So I'm sorry, I'm using my computer. The phone is so tiny for my eyes. So question 3 continued. Number 3, in what ways are they different? What I found about that is that the diagnosis of mixed mood states are distinct as an entity, but then they are being replaced by mixed features. And those mixed features makes for its specifier for both mania and major depressive episodes. In the DSM-4, a mixed mood state could only be diagnosed if patients met the full criteria for both mania and major depression. But since then, this was the case when it was mixed and it was rarely diagnosed. This led to bipolar depression being frequently diagnosed as unipolar depression and being treated as that. And then the fourth question, can you think of other ways in which the mood disorders might be subdivided into more homogeneous subtypes? I think the allowance of a diagnosis of bipolar when mania or hypomania occurs in a patient receiving antidepressant medication is consistent with data indicating that such patients do not differ from other patients. No other changes were made in the core criterion, symptoms or duration criteria for for mania, hypomania, or depression, major depression. So I concluded by saying, based on the evidences I gathered so far, I concluded by saying that for patients like George, who has exhibited manic and depressive symptoms, his problem will be diagnosed as bipolar disorder. That's according to Ottman et al., 2011. Anyone who has experienced a manic episode is assigned a diagnosis of bipolar 1 disorder, according to the DSM-5. The DSM-5 manual notes that the person may have experienced depressive episodes before or after the manic episode, but these experiences are not required for the diagnosis of bipolar. Next slide, please.
So the question of whether individuals with bipolar disorder are more inclined to seek and engage in stressful activities in occupation is kind of a complex question. While there isn't a definite answer or definitive evidence that suggests they actively pursue stress, they may experience heightened vulnerability to stressors compared to those without the disorder. Stressful situations can significantly worsen symptoms or even trigger relapse in individuals with bipolar disorder. This heightens susceptibility or even triggers relapse in individuals that may factor in the symptoms. Therefore, while they may not actively seek out stress, individuals with bipolar disorder may find themselves disproportionately affected by stressful circumstances, emphasizing the importance of stress management and support in their treatment and management. So our case summary is that George's story illustrates a series of manic and depressive episodes, indicating symptoms consistent with bipolar disorder. His behavior ranges from excessive energy, rapid speech, delusion during those manic episodes to have severe depression and lethargicness and suicidal thoughts. George's histories includes periods of increased energy, inhibition, often unnoticed or dismissed, as well as times of deep depression. Despite treatment with lithium carbonate and therapy, his condition severely impacted his personal and professional life, leading to divorce and ongoing challenges in managing his mood swings. This case highlights the complexity of bipolar disorder and the importance of comprehensive treatment approaches. This is our reference page that we have used throughout our project. And following this one are two other reference pages that we put all our references on. And here are credits. Us as a whole group did the narration, and then the research was done by Robbie. The designer and editor was Madison and Deja. The facilitator and writer was Leslie, and the format and cleanup was me, Lauren.
And